based on what you've told me, a 5.5 PSA, one core out of a lot, Gleason 6, without knowing the percentages of it, you're either low risk or very low risk prostate cancer, okay, which is good. That type of prostate cancer statistically is not going to kill you, okay? It's you, based on what you've told me, and I don't know the specifics of your disease. I haven't seen obviously your paperwork, but in those patients, typically the first consideration would be active surveillance, okay? It wouldn't be treatment. And active surveillance over the last 2 years has become a big part of our treatment, regimen, is to offer that. And that's been a major shift in prostate cancer the last 2 years. And what active surveillance involves is basically a PSA every 3 to 6 months, digital rectal exam every 3 to 6 months when you visit the urologist, and typically a biopsy every 1 to 2 years afterwards. 70% of the patients that go on active surveillance typically will stay on active surveillance for the rest of their life. About a third of those patients will progress to disease, to treatment. The reason that patients will progress to treatment is very mixed. Sometimes it's psychological. Sometimes guys will say, I'm sick of this. I'm sick of these biopsies. Leave me alone. Let's treat this and move on. Sometimes we will actually see your Gleason score worsen. It may go from a 6 to a 7, and obviously the higher the Gleason score, or even sometimes a higher PSA, which is not the best marker, will also trigger treatment, But active surveillance, about 40%, the last look at it in this country is, of the patients that present with prostate cancer, 40% of those patients will go for active surveillance across the board. Probably that number will continue to rise over the next couple of years, is that we're going to be placing more patients on active surveillance. Because 2 years ago people would think that's a crazy idea, but now it's pretty well accepted across the country. In addition to active, what also has made active surveillance more tolerable or palatable to patients and physicians is that we have new molecular markers that can predict outcome, okay? So we can actually take the RNA and the proteins within your prostate cancer of your tumor, send it out and do further analysis to further predict the likelihood that this cancer can come back, that likelihood that this cancer would spread. And that's been a major breakthrough with how we treat prostate cancer. So typically when I put patients on active surveillance, I'll order additional molecular markers to determine, is this really a Gleason 6, okay? Because, that determination is not always perfect. And this gives us another layer to say, yeah, it seems to be a Gleason 6. That being said, these molecular markers also aren't perfect either, but it gives us more information to say, don't worry about it, we don't need to treat it. So another way to look at active surveillance is timing of the treatment. I just said that, the majority of them we don't treat, but sometimes, a lot of times, we don't have to treat your disease when it's a 6. If it was to progress and develop into a more aggressive disease, then we would, treat you at that time. So active surveillance is probably not the best term for what we're doing. It's timing your treatment for when it's appropriate.